Hello everybody. As Philip said, I'm going to talk about antipsychotic medication. I was actually given quite a number of different topics that have been requested, which I can't obviously do in just a short half-hour session. I therefore picked the most common theme, which was about adverse effects, and the theme seemed to be that a lot of people wanted information about antipsychotics particularly. So I've picked just a handful of adverse effects to talk about. There are obviously loads more, and I'd be happy to answer questions at the end if people have other questions that perhaps I haven't covered. And I've also said, as there were quite a lot of medication-related topics that I was given, I'd be obviously very happy to come back at another time to pick up some other issues. So what I plan to do is just give a really brief reminder, an overview of the types of adverse effects. Then, as I said, I'm going to concentrate on just a handful of antipsychotic problems that we come across when we use antipsychotics. So extrapyramidal side effects, the metabolic syndrome. I was asked to talk about cardiac adverse effects, but I think that's a massive topic on its own. So I've just picked out QT prolongation. And then I can't help myself, I have a massive thing about clozapine, and I know perhaps in primary care you're not necessarily prescribing clozapine, but there are so many different side effects that I could talk about. I've picked one that I wanted as primary care clinicians you to just kind of think about, which is constipation. I have put a few slides at the end which I may or may not have time to talk about, but they're links to bits of useful information and patient information. So hopefully in the next 25 minutes or so that's what I'll cover. So this is probably just as a reminder, and just to kind of set the scene really. Types of adverse reaction are generally broken down into two main groups, types A and B. Type A are those that we can predict if you look at the pharmacological action of the medicine. So they're what we expect will happen. Doesn't mean everyone's going to get them, and they are related to dose. So we would know that if you either start with or go up to a higher dose, you're more likely to experience this type of side effect. Type B reactions are the ones where we just can't predict them by looking at the pharmacology of the drug. These account for far less than type A effects, and often we don't really pick these ones up necessarily until the medicine has kind of gone through clinical studies and been launched and licensing is out there being used. So these are usually the less common type of side effect. I have put in there that there are other classification systems, C, D and E. I don't know if people are interested, but C is where it's sort of an ongoing chronic type of problem. The example the MHRA give for this one is osteonecrosis of the jaw with bisphosphonates. D is where it's perhaps difficult to pick up, so it may be that you've given a dose, a one-off dose of something to somebody, and a few weeks later they develop a side effect, which we know is linked, but it's something that it doesn't happen straight away. And then end of use is where you stop something and you're getting problems. So the typical benzodiazepine withdrawal type issues would be given that kind of category as well. So just a few examples of type A, I'm sure everyone can think of lots. But if we're giving a tricyclic antidepressant, we know we're going to cause some anticholinergic adverse effects like dry mouth, blurred vision. Or if we give quetiapine, which is quite a strong alpha-1 blocker, we're going to maybe expect a degree of lowering of blood pressure. Type B would be the things like clozapine. So we can't predict who's going to get neutropenia, which is why we're on it at the start of treatment every week. We're checking full blood counts. So we know it happens, but we can't predict who it will happen in. And then the other example is Stevens-Johnson syndrome in the watch gene. We know if we do certain things with medicines, we might be more likely to see those side effects. So if you start with a really high dose, or if you use it with valproate, but again, we can't predict in who that will happen. I'm sure you're all extremely familiar with this as well, but just it can be helpful when we're talking to patients to be able to quantify stuff. So if we say, a side effect's very rare, what what does that necessarily mean to a patient? And these are the standard definitions that when a product is licensed, the manufacturers will put these incidence figures against their side effects. So to talk about antipsychotics, we use them for their beneficial effect of reducing psychotic symptoms, hallucinations, delusions, and we want it to work a particular pathway within the brain. They're obviously not only going to affect those pathways, they're going to affect several other pathways. And if we're thinking about extrapyramidal side effects, they are primarily related to blockade that occurs within the nigrous striatal pathway, but not exclusively so. So when we think about certain types of movement disorder, things like akathisia, we don't fully understand why that happens, but it's possible that there's some effect in the mesocortical tract as well. So primarily we're looking at the striatum. These are type A adverse effects. We know if we're going to give a dopamine antagonist to somebody, that they may experience an extrapyramidal side effect. And if you give a high dose, you're going to be more likely to. So they're dose related and linked to the potency of the antipsychotic as well. So if you've got a high potency, generally first generation antipsychotic, given a high dose, you're probably going to cause someone to have EPS. So lower risk are not all of them, but some of the second generation antipsychotics, things like clozapine, quetiapine. But there are other pharmacological reasons why we think they have a lower rate of causing EPS as well, which I'll come on to in a bit. So once present, they may persist, these type of side effects, but I've got a graph at the end to show that for a lot of them they do actually improve with time. And we think possibly there's some genetic determinant as well around why people might be more susceptible than others to develop this kind of problem. So they've been named different things, but the second generation antipsychotics, atypicals, also known as serotonin dopamine antagonists, have a lower incidence because we think that because they act on the postsynaptic receptor on a dopamine neuron, dopamine acts there to actually prevent the release of dopamine. If you inhibit that, you're inhibiting the inhibitory response. So dopamine actually increases. So these second generation antipsychotics have that effect in all areas of the brain, and we think that doing that in the nigrous striatal pathway means that there's a lower incidence of EPS there. Obviously, it's a little bit counterintuitive because we think if we're causing more dopamine to be released, that would have an effect on the antipsychotic effect, but it doesn't seem that there's enough of that to cancel out the beneficial effects. But that also might explain why they have lower, not all of them, but lower rates of prolactin increase as well. So Parkinsonism is a problem for about 20% of people treated with antipsychotics, particularly those treated with first generation. And it mimics exactly what you would see presented if someone had Parkinson's disease. The elderly, more at risk, and females. And it's usually seen earlier on in treatment, so it's not, unless you're increasing the dose later on in treatment, obviously. So it's something associated with the first kind of weeks of treatment. It's a type A adverse effect, so like I said, related to dose. What you would try and do if you can, not always possible, is to swap to something with a lower risk of causing this side effect. If that's not possible, there is the option to prescribe another medication to treat the side effect, and we would use an anticholinergic like precyclizine. Obviously, it brings its own set of side effects. It's an anticholinergic, so you've got problems like I've kind of alluded to with the tricyclics, the dry mouth, that sort of thing. There's an increased risk of it causing, if you carry it on longer term with an antipsychotic, there's an increased risk of developing tardive dyskinesia as well. And certainly we'd be worried about cognitive impairment, particularly in elderly patients. So probably what I would kind of highlight is the fact that we would need to be kind of on it, reviewing it quite regularly. This type of side effect can improve over about 3 months. It may not completely go away, and it doesn't always improve for people, but certainly on a 3-monthly basis it's worth seeing whether you can reduce the dose or even stop medication. Acute dystonic reactions, we are probably seeing less of, but that's probably because we're using fewer first-generation antipsychotics. And that's the group of antipsychotic that they're more likely to be seen with, particularly if you're going with a high dose or high potency medication like haloperidol or zooplopentixol, something like that. However, I mean, my specialty clinically is with CAMHS, and I work on a high-field unit at the Warnford. We don't use first-generation antipsychotics, well, very rarely. But I have seen this kind of side effect with medicines that probably more strongly D2 receptor antagonists out of the second-generation antipsychotics, like risperidone. And that's because we're probably using them in younger patients who are more at risk of this side effect. So even though we would think of those particular medicines as lower risk, it can still happen. So I've seen only a handful, someone with torticollis, someone with an ocular gyrate crisis on risperidone. So the younger group and males are more susceptible, and particularly if they've not had an antipsychotic before. So I think that's where this small group of patients where I'm sitting could be particularly susceptible. I'm sure, as you know, treatment needs to be really prompt, and it would be with an IM injection of cyclidine, and response is pretty quick. So if we're seeing that kind of problem, we want to review what dose we'd use, have we gone into too high, are they, I mean, if they've had that kind of effect with one strong D2 blocker, we'd probably want to avoid using another one and to use something, a second generation antipsychotic with less potent D2 blockade, so clozapine, maybe not clozapine the second line, but olanzapine. So akathisia, as I mentioned before, we're not fully sure of the mechanism, but there may be some involvement of the mesocortical pathways as well. And it's more associated with the first generation antipsychotics, but actually aripiprazol's got a pretty high incidence of akathisia, and definitely when doses are used you start too high or the titration is too fast. So if you look at the manufacturer's guidance on in adults, if you start aripiprazole, for schizophrenia, the recommendation is to start with 10 or 15 milligrams a day, which I personally think is pretty high to go in with as a first dose. And then for bipolar, it says 15, so people are manic patient. So we would probably, I think the company would also say it's probably worth starting with something like 5, even if it's just for a few days. If you look at the recommendations for younger people, the manufacturer says start at 2 milligrams, so kind of just in comparison. And that is primarily to reduce the incidence of akathisia. But it is a side effect that can improve with time as well. It's not very pleasant for some people. So the decision, you'd have to keep reviewing, and the decision would need to be depending on how bad the person was finding those side effects as to what you did. Either swap to something with lower risk, or if you can encourage a patient to persist with treatment if it's not too disabling for them, you might see an improvement with time. Obviously, primarily the first thing would be to, if you can, reduce the dose if it's appropriate, but that might just relapse or return of symptoms. Just to point out, it's obviously, you have to balance the risks. There is a higher risk of suicide and aggressive behaviour as well if people are experiencing akathisia. So it may be just better to try and find something that suits them more. So as I said, the first thing would be to reduce the dose because it's a type A dose-related effect. Switch to something different if you can. If you're kind of at the end of the line, we would tried other things already and this is actually treating them really well, but it's caused akathisia, you might then want to add in one of these other treatment options. There isn't a huge amount of evidence or supporting literature behind these. There's some, and we'd probably think of propranolol or clonazepam as a first-line treatment if you couldn't switch your antipsychotic, and can be effective for a proportion of patients. Again, obviously brings a whole load of other side effects with them that you'd have to balance the risk with. None of them are licensed either, so it would all be off regulatory. So this brings me on to tardive dyskinesia. Again, we don't fully understand the mechanism. This is a kind of a later onset adverse effect of antipsychotics. We think it may have something to do with upregulation of D2 receptors and kind of supersensitivity presentation, and then a misbalance between D1 and D2 receptors. And that might also explain why you sometimes see either a kind of bringing on of tardive dyskinesia or a worsening of it when you stop an antipsychotic. The main thing to do would be, if you've identified it, to try and do something about it quickly, because for about half the patients it's actually irreversible. Some patients don't find it bothersome, but it's the people that are with the patient that might find it more disturbing. Anticholinergics can make it worse. If anyone's on an anticholinergic medicine, that needs to be stopped. Reducing the dose cautiously and carefully is the kind of main thing to do, but ideally you'd be looking at an alternative with a lower risk. And clozapine's got quite a lot of evidence behind it for being actually quite a good treatment for tardive dyskinesia. So clozapine doesn't really have, it's not really associated with many movement disorders itself. Tetrabenazine is the only licensed preparation. I think there's another product either on its way or it has just been licensed. It doesn't have masses of evidence behind it, but it has got product license. But it has numerous problems associated with it, so it can cause depression and actually movement disorders of its own. For some people it can be helpful, particularly where other options have either been ruled out or have failed. Interestingly, ginkgo biloba, I'm not sure if I'm even saying that properly, biloba, the herbal medicine has probably, out of everything, the best evidence for treating tardive dyskinesia, and it features in the American Academy of Neurologists tardive dyskinesia guidelines. They've done a massive review of everything that's been trialled, and that kind of graded the levels of evidence. So everything else has kind of weak or limited evidence, and ginkgo and also clonazepam has what we would class as moderately good evidence for helping. Again, it's probably not something we can necessarily prescribe, but I don't know what your thoughts are about suggesting it to people as an option that they could buy. So this is just a graph of the time course, just to kind of show that on the whole, these problems can get better. I've put tardive dyskinesia there. I mean, I guess it could occur as early as 12 weeks, but usually this is not going to see months or years down the line. Okay, so that brings me on to sort of metabolic problems associated with psychotics. Weight gain is a massive issue with a lot of our antipsychotics, but particularly the newer, well, they're not new anymore really, but the second generation antipsychotics, things like olanzapine probably, is what the metabolic syndrome, when they became available, there was a lot of press and published literature about this issue. We're starting with a group of patients who probably don't have particularly great self-esteem and probably relatively poor self-care. Physical health might not be great, and if we're going to then start causing additional problems as a result of adding weight on, long term we're not really helping our patients terribly well. Weight gain specifically, so I'm going to come on to some of the other metabolic issues in a minute, but weight gain specifically, if you're younger and female, you're more at risk, and certainly on Highfield, we are trying not to use olanzapine anymore. It's absolutely everybody we started in gains weight, and we've seen, like, I don't know, 10, 15 kilos, and people breaking into the clinic, the canteen area on Highfield to try and get food, just massively stimulated by olanzapine in terms of appetite. The mechanisms, again, aren't fully understood, but there are probably numerous ones. I think increases in leptin levels have been shown to be quite clearly associated, but this appetite drive, is kind of well known. Right, I'm going to speed up a bit. So, managing weight gain, the BAP guidelines, the British Association of Psychopharmacology, have put out some really good guidelines about managing metabolic complications. So I'll probably just, as I need to speed up, just draw your attention to them. They also cover the use of adjunctive treatments like aripiprazole, which causes weight loss, or can cause weight loss, and also metformin. So I'm not sure if people are seeing combined metformin with antipsychotics, but there's a lot of good evidence that this helps with weight loss that's been caused by antipsychotics. For quite a number of years we've had a guideline for our CAMHS service, so I think that's where the information sort of started out, but there's loads of evidence in adults as well. Diabetes is a high incidence of diabetes in schizophrenia anyway, so it's a genetic link, it might be linked to lifestyle, but then we're going to add an antipsychotic, which might then increase somebody's risk. This kind of problem is known with the first generation, but it seems to become much more evident with the second generation antipsychotics. Again, the mechanism's unclear, and it can actually occur without weight gain, so it's not just specifically to us causing weight gain with an antipsychotic. The highest risk are clozapine and olanzapine, so olanzapine's kind of not brilliant for a lot of things, sadly, because it's quite a good antipsychotic. Lowest risk with aripiprazole and sulpride, lorazepam, and again, it seems to be a higher risk in younger people. That might be to do with the prevalence of diabetes in that group, so we don't want to see type 2 diabetes in really young people. We probably are more so. Lipids is another thing that antipsychotics can affect. They can affect cholesterol, but I've highlighted the fact that the biggest issue is probably with triglycerides in terms of magnitude of effect. With the first generation antipsychotics, it's less kind of well quantified, but certainly with the second generation, olanzapine again, it's well known to cause quite significant raises in triglycerides. So if you're seeing that kind of problem, certainly if you're seeing patients with glucose tolerance problems on one of these, we would want you to swap to something lower risk if we can. But again, monitoring is key. We've got some quite comprehensive monitoring guidelines for the Trust in terms of what we'll be looking at and how frequently. Prolactin, I was asked to talk about prolactin. I've only got a couple of slides on this. I won't go into mechanism, I briefly touched on that earlier. Often patients can be asymptomatic, and probably what we want to be thinking of, because it's very easy to sort out and identify people who've got the acute problems like gynecomastia, galactorrhea. What we're thinking more is longer term. So this is the risk of causing osteoporosis, because prolactin can cause hypogonadism. So we'd be really wanting people to keep asking women about menstrual history, and if patients' periods have stopped, we would be either wanting to stop treatment or be thinking about maybe replacing with an estrogen, so from a combined contraceptive or HRT. I did have a link here to our guidelines. We've got some Trust guidelines on managing hyperprolactinemia, which are quite comprehensive. We linked up with the endocrinology services across all of the counties we cover. So perhaps, unless people can ask me more about that at the end, if they want. This is a slide that highlights you won't be able to read this, but just the pathway that we would want people to follow. Really important to take a baseline prolactin level prior to a prolactin-raising antipsychotic. And the follow-up, hopefully highlighted by this guideline, the aim is to try and get away, reduce the number of prolactin measurements that are being taken. Take a prolactin measurement, it's raised, but what do we do about it? I think was certainly for our clinicians, one thing that this guideline was kind of aiming to help with. Right, I need to finish up. I haven't really come on to the QT prolongation.
Slides will be available.
They will, yeah. So I was going to I only had a few slides on this, but it might be helpful for people to see two slides that kind of categorise the risk to QT, and obviously come back and read the slides later. This is directly out of the Maudsley prescribing guideline, which is brilliant reference if people haven't seen it. This table categorises them in terms of no effect, low effect, which we would say is a sort of a change of less than 10 milliseconds, or a significant effect in overdose. And this is what we would aim to do about it if we were seeing a problem. So I'll put those in, I think maybe would be helpful slides. I haven't come on to constipation, and I'm going to need to stop. But so I haven't been able to talk about my favourite topic with clozapine, sorry about that. Yeah, but the slides will be available.
Thank you very much.